Hi everyone. So this lecture and the next lecture are really going to build on all of the principles and fundamentals related to public health surveillance that we've covered over the last few months and bring us to a new level of public health surveillance related work, which is leveraging public health surveillance data for more in-depth epidemiologic analyses. So I'll provide some background and go through some examples, and next week Jenny Shen is going to go through some more examples. Many of the examples showcase that there are sometimes real opportunities to be creative in using surveillance data to answer an epidemiologic research question. So first we'll go through the lecture content, and then at the end I'll say a little bit about the final exam. So you'll remember this diagram from early on in the course about the public health approach and where surveillance fits into that public health approach. I also mentioned at that time that I view surveillance as having a role in kind of a feedback process whereby, once we begin to implement interventions and at scale, surveillance can then play a role at evaluating the impact of these public health responses. And so this is a theme of some of the examples that I'm going to talk about today. So first, just taking a step back, why do additional analyses and more advanced epidemiologic analyses using surveillance data? A lot of our work has really focused on using the data in the surveillance system to solely focus on achieving the goals of that surveillance system. But once you have these data, they present lots of other opportunities for you to do potentially important work. Some of it relates to the descriptive analyses that we've been talking about, and these tell you a lot about what's the problem. But sometimes when you do these kinds of analyses, even when you identify risk factors, it often can raise new questions that are important to answer. And sometimes these questions can be answered in whole or in part with the surveillance data that you already have. And so it's important to look for opportunities to use the surveillance data that way. And I would argue that in general, surveillance data are often really undertapped in terms of their potential to shed more light on public health problems and answering public health research questions, or just general important public health questions or evidence gaps. So can we think about going beyond the descriptive work to look at associations and often to try to get at why? I think I'll make the case that it's possible to use surveillance data in this way, but too often, in my view, it doesn't happen. And why are surveillance data often overlooked when it comes to these kinds of epidemiologic analyses? Well, part of it has to do with time and capacity in health departments. There's often no time to go beyond the basics of what's part of the surveillance system's day-to-day activities. Sometimes it relates to capacity to complete these kinds of analyses. And then, thinking about outside of health departments, sometimes it's hard for researchers who are outside of the health department to get access to the data that might be used in this way. And I would say, I think this is improving over time, but in general, surveillance data can be looked down upon, especially by people who are outside of health departments, and they have kind of a bad reputation for being messy and incomplete. And in general, they might not be collected for the very purpose of the particular analysis or research question that you're trying to answer. They do, as we've discussed a lot, have many limitations. People generally think surveillance data are good for hypothesis generating, but not necessarily hypothesis testing. People view it as unglamorous or biased. And for academics, they're often looking for funding to support the research that they want to do, but the surveillance data don't come with funding. And, there's sometimes a feeling like, well, if it could be done, someone's already done it because the data are there. But that's not always true. As you'll see, there's often opportunities to go well beyond the routine work. Some of these things that I've listed here, do have some truth to them. But I guess my point here is it doesn't really mean that surveillance data can't be used at another level. And to me, the real question is, are these limitations a problem such that it will get in the way of conducting a specific analysis that you're trying to do, to the point where it shouldn't or can't be undertaken. And as I think you'll see, often a great deal more can be done with surveillance data in terms of epidemiological analyses. So when thinking about going beyond the basic work of the surveillance system and related analyses, what are some considerations? First, what is the primary question you're trying to answer or address? And then beginning to be more specific about details. What's the outcome that you're going to be using? How will you define it? And then, related to epi analyses, what's the exposure of interest and how will that be defined? The exposure in this case could be, a policy change or a new intervention that's been scaled up. And then thinking about the outcome and exposure, what measure of association are you going to be estimating? In general, it's important to take a really practical approach to these kinds of analyses. You really need to know the inherent limitations of the surveillance system when you begin to jump into these analyses. I also think it's very important to do data visualization type work, so graphs and plots and maps and things like that. And then never jump right into multivariate analyses. It's really important, as it is with all epi-related analyses, proceed from the simplest to the most complex. So start with univariate analyses, then do stratified analyses. And then when you're comfortable that you understand what you're beginning to see in the surveillance data, you can move on to multivariate analyses. And certainly it's important to always realize when the inadequacies of the data preclude the more sophisticated analyses that you may be trying to do. And in fact, you may hit a wall when you're trying to do something with the surveillance data, and in those situations you might need to do some kind of specialized study that's either cued off of the surveillance system and building on it in some way, or independent of the surveillance system. So in these kinds of analyses, here's what you have to work with. You have some kind of surveillance data set, and that could be data from a reportable events type of database or registry data. You have survey data that health departments may collect routinely, such as BRFSS, or in the case of New York City, community health survey data. There's hospital discharge data, like the SPARCS data that we covered, data from vital records or vital registration on births and deaths. And sometimes you'll have Haynes-like data, so N-Haynes or C-Haynes, where there's not only just questionnaires and interviews, but specimens that have been collected for laboratory analyses and also clinical examinations that have been done. So these are the data sets, often an example of the kinds of data sets that you'll have to work with. And then you can add things to the surveillance data. The most obvious is just sort of calculating new variables based on the data that you already have in surveillance, but you can also think about bringing in data from other sources, such as the census data, bringing in denominator information to calculate rates for the outcome. Or you can think about group level variables from census data. You may not have, for example, say income related information in the surveillance data set, but you could create neighborhood level or group level information on, say, the proportion of people in different income categories in a neighborhood and use that in your analysis. Survey data like CHS can be used as a denominator or as group level variables. You can link to other surveillance systems. We've seen a few examples of that, and I'm going to show one later today. And then, there are other data that are outside of surveillance, such as administrative data or intersectoral data that you can think about. Common outcomes are, those typical to epidemiologic analyses. But with surveillance, you have things like cases or new diagnoses, deaths, a behavior or some kind of exposure. And, within each of these reportable events, let's say it's, HIV cases, there may be epidemiologically important groups to examine, and we'll see one of those groups in today's presentation. For example, people who receive an HIV diagnosis who are in the advanced stages of HIV at the time of their diagnosis. That's an example of an epidemiologically important group. You can look at outcomes like proportions and rates and time to event, and ultimately you'll be looking at measures of association that many of you in epi many of you encountered in your epi courses, such as relative risks and odds ratios and so forth. So where to start your analyses? So always important to articulate and refine the epidemiologic question. What are you estimating? Is it an incidence type of an outcome or a prevalence type of an outcome? Are you going to be trying to assess the impact of some new program or policy that's been implemented? Are you aiming to characterize disparities or health inequities? Or are you trying to identify or assess potential mediators of an exposure outcome relationship? As before, have a good understanding of the strengths and limitations of the surveillance system and its data, and articulate the goals of the analysis. So I list some examples here. It could be to examine trends, but also you're going to be moving into looking at associations between two or more variables. You'll develop table shells to think through the analyses that you have planned, moving into an exploratory data analysis phase, which I say here, be sure to stay focused. It can be easy to get distracted in these kinds of analyses because there can be so much to look at. But when you do this exploratory data analysis, you're getting into things like, do you have all the data that you might need to conduct the analysis you want to? Are they clean enough? What might the missing data challenges look like, and can you develop reasonable plans to handle them? And as I mentioned before, data visualization is key. Include lots of plots and graphs and maps in your exploratory data analysis. And this is not a new slide, but just to remind you, these are some of the common limitations that we've considered that also come into play when you're doing these kinds of more advanced analyses of the data. Incomplete reporting, the lack of representativeness that can happen, and this can induce selection bias. Lack of timeliness of the data. If you're combining data across jurisdictions or across time periods, you need to be wary of potential changes in case definitions or differences in case definitions. And how incomplete or inaccurate is the information that comes to the health department on the case reports that come from providers or labs. And how much is there a reliance on self-reported data or recall for some of the critical variables that you need in your analyses? And then you need to think about how these things will potentially impact the analyses you're trying to plan. So the three examples I want to cover in today's session relate to the first question here is did expansion of HIV testing in New York City reduce the rate or the frequency of late HIV diagnoses? The second one is, did the flu vaccine cause a spike in reports of a rare neurologic syndrome to the Vaccine Adverse Event Reporting System, or VAERS? And then the third one is New York City's HIV care coordination program effective at improving viral load suppression levels for HIV compared with a usual care comparison group? So these are three questions, and hopefully they jump out at you as being quite a bit more specific than the goals of the more broad goals that surveillance systems have. So in this first analysis led by Yusuf Ransom, the goal here was to estimate the association of expanded HIV testing coverage on the rate of late HIV diagnoses, which, as I mentioned, the outcome with HIV surveillance, all new diagnoses of HIV are reportable, but the focus on people who have advanced HIV disease at the time of their diagnosis is an epidemiologically important group that was the focus of this analysis. And it's an example of an epidemiologic use of surveillance data that I want to highlight because it uses two different surveillance data sources to gain insights about where public health programs are impacting outcomes that you wouldn't really be able to get at with either data source on their own. So just by way of background, at the time that this analysis was conducted, People who were diagnosed with HIV and AIDS at the same time, which we call late HIV diagnoses, accounted for about 20% of all new diagnoses in New York City. And why is this important? Well, at the individual level, a late HIV diagnosis is associated with higher rates of short-term mortality, admission to the hospital, and opportunistic infections. And also from a societal standpoint, there's a much higher direct medical costs following HIV diagnosis. And at the population level, being diagnosed with HIV late means that someone has had HIV infection likely for maybe 8 to 10 years before they are aware of it, and that could have resulted in onward transmission and contributing to the burden of HIV incidence in the population. And we do know from clinical trials now that reducing late HIV diagnosis accompanied with a timely initiation of treatment can reduce onward HIV transmission. Also, some related background in New York City, there were a lot of public health efforts to try to increase HIV testing coverage that were undertaken at different time points that were in the analysis period here. So in 2007, CDC funded many different jurisdictions to expand HIV testing, including New York City. In 2008, the New York City launched an initiative in the Bronx to increase the proportion of people who are aware of their HIV status through testing. They did the same in Brooklyn in 2010, and by 2014 they had expanded to all 5 boroughs through the New York Knows initiative. This latter expansion wasn't part of the analysis that I'm going to present to you, but just to give you an idea of in the background, there were several efforts aimed at increasing HIV testing coverage around the city. So, stating the objectives of the analysis, the hypothesis here is that expanding HIV testing and adequately targeting HIV testing in the population to improve coverage could result in people with HIV being diagnosed earlier than they otherwise might be on a population level. And this is just sort of a little bit of a dag here. If you increase HIV testing coverage, that can result in earlier diagnosis of HIV on average, and this in turn will reduce the rate of late diagnosis in the population. And then not shown here is that it could also reduce mortality and incidence. And so the goals of the analysis were to describe citywide trends in recent HIV testing coverage and in late HIV diagnoses during this time period, 2001 to 2010, which, as I showed, was a period where there was a lot of effort on the part of public health and the health department and CDC to increase HIV testing coverage. And within New York City neighborhoods, a key question here was, were increases in recent HIV testing coverage associated with decreases in late HIV diagnosis rates during that time period? So I know that you all remember where we might get information on late HIV diagnoses each year in New York City, but maybe less obvious is where we would get information on what happened with HIV testing coverage and how that changed over time. Well, it turns out that the New York City Community Health Survey asked questions on HIV testing each year that it was implemented, and so it was possible to know, not only from this population survey of the adult population, it was possible to know not only had people ever had an HIV test, but a question was asked whether or not people received an HIV test in the last 12 months. And so we called that recent HIV testing, and we looked at how that changed within neighborhoods, because the Community Health Survey does produce estimates at the 34 UHF neighborhood level. And so that was the exposure, HIV testing coverage, and how it changed within neighborhoods over time. And then the outcome was late HIV diagnosis, which, as you might imagine, came from the HIV surveillance system, the registry in New York City. And we defined a late diagnosis as having these criteria: a CD4 count less than 200, or an AIDS-defining illness within 1 year of an HIV diagnosis. And then we used census data to calculate the rate per 100,000 population of late HIV diagnosis. And this was important because we're looking in neighborhoods, and if we were just looking at the numbers and comparing the numbers of late HIV diagnosis, we wouldn't be able to compare neighborhoods. Every neighborhood has a different number of people living in it and a different number of people with HIV. And so we needed to bring in denominator data to use rates as the outcome. So this is a visualization, a set of maps that's showing not just what the HIV testing coverage was in New York City, but how it changed over time. And so we have changes in HIV testing coverage on the left and changes in the late HIV diagnosis rate on the right. And the red areas are showing those neighborhoods where HIV testing coverage increased the most. So from an increase of between 9.6% and 23.6% between these time periods. And then on the right here, we're seeing where the rates of late HIV diagnosis changed the most. And the red areas show those areas where it declined the most. And so just here visually, you can get a sense of seeing a little bit of overlap of where HIV testing coverage increased the most also happens to be, looks like it's correlated with where late HIV diagnosis rates went down the most. And here we just kind of took that data, another example of visualization, and plotted it. This is the neighborhood level data in the change in the HIV testing rate here on the bottom. So those neighborhoods where it changed the most are on sort of this end of the axis. And here we have changes in the late HIV diagnosis rate. And so those areas where it decreased the most are sort of in this end of the axis. And the different colors here show the rates for males and females, males in blue and females in orange. And the sizes of the circles represent the number of late HIV diagnoses, just so you can get a sense of how that varied a lot from neighborhood to neighborhood. And here you can visually sort of appreciate a potential relationship such that where HIV testing coverage increased the most, there tended to also be larger decreases in the late HIV diagnosis rate. And of course, we went on to do some multivariate models here to, again, at the neighborhood level here, looking and showing that the neighborhoods with the largest increases in HIV testing coverage during that time period were significantly more likely to have the largest declines in the late HIV diagnosis rates. And interestingly, the association was stronger and more significant for males and not so much for females. And so thinking about the strengths and limitations of these kinds of analyses, it's important to think about the numerator and the denominator used, the outcome definition and the exposure. Here you're thinking about things like misclassification, completeness of reporting, which in the case of the HIV surveillance system we know is quite good. And we also, we know the limitations of survey data where we might be ascertaining HIV testing coverage. But the question is, are these limitations such a problem either on their own or when combined with other limitations that it really gets in the way of achieving the goals of the analyses? And you're asking questions like, do the conclusions go beyond the data given concerns about biases? These are, I think, the kinds of things you want to be thinking about as you're planning your analyses or as you're interpreting someone else's analysis. But you can see here, I think the conclusions were reasonable. Increases in recent HIV testing coverage may have reduced late HIV diagnoses among men in New York City. The persistent geographic disparities that we saw even after this expansion argued for more expansion of HIV testing to promote earlier diagnosis. And that's in fact what New York City did with the continued expansion into the New York Knows initiative. So the next example that I want to present to you is to assess in the 1992 and 1993 flu seasons whether or not the influenza vaccine increased the risk of Guillain-Barré syndrome, or GBS, during a period where there was a spike in reports to a surveillance system of vaccine-associated Guillain-Barré syndrome cases to the vaccine adverse event reporting system. I'll go into a little background on this in just a second. And why I think it's a useful example to present in this lecture is because it's an example of how sometimes a surveillance system might not have everything you need. And when you combine information with the surveillance system with supplementary data, you can get much further in getting an answer to your research question. So in this case, it was collecting supplementary data on patients identified using hospital discharge data under a research protocol that really augmented the utility to address this question. So here's a little bit of a background. There has been a history of the flu vaccine known to be causally associated with Guillain-Barré syndrome. It happened in the year of the swine flu vaccine, a year when there was a lot of worry about this particular strain of flu, and a special vaccine was made and distributed, and there was a large increase in the risk of Guillain-Barré syndrome, with relative risks ranging from 4 to 8 within the 6 weeks after vaccination. In other years, not those years of the swine flu vaccine, the relative risks were closer to the null, ranging from 0.6 to 1.4. Now, there is a surveillance system called a national surveillance system in the US called the Vaccine Adverse Event Reporting System, or VAERS. It's run by the FDA and by CDC in concert. And it receives reports from not just providers, but anyone from the public on adverse events that people think may be related to a vaccination that they recently received. And so these reports are received by VAERS, and you can think of it as a type of surveillance registry. But keeping in mind the source of the reports can be from healthcare providers, or even you as a person who receives a vaccine. If you feel that there's an adverse event that was caused by that, you can file a report with VAERS. So these are the kinds of things that make their way into that system. And looking at the VAERS data, this is a graph showing the number of Guillain-Barré syndrome cases that were reported to VAERS over time. And you can see, starting in 1991 and 1992 flu season, the cases nearly doubled year over year after that. And so the question was, what's going on here with Guillain-Barré syndrome following vaccination? Remember, all the reports to VAERS are following a vaccination, and this graph shows Guillain-Barré syndrome cases that people associated with their flu vaccine receipt and the trend over time. And so it became important to understand, is this spike in Guillain-Barré syndrome cases something that is causally related to the flu vaccine? Harking back to those years in the 1970s, where we saw a very real and significant increase in Guillain-Barré syndrome after flu vaccine. So the objectives of this analysis were to examine the relative risk of GBS associated with influenza vaccine in 1992-93 and 93-94 flu seasons. And really the question here is, was the increase in reported cases of GBS to VAERS caused by the flu vaccine? And so, you probably already have a sense of this, but the problem with VAERS, using VAERS alone to do this kind of analysis, is that of the 2x2 table that we all know very well, exposed and unexposed cases and non-cases, really only cell A here is represented in VAERS. Only exposed vaccinated people who have an adverse event are captured in VAERS. So it's useful for detecting potential safety signals, but further epidemiologic investigation will be required to understand whether or not those safety signals are a causal association. So how did we proceed with this analysis? So we queued this study off of hospital discharge databases in 4 states. And there is an ICD-9 code for Guillain-Barré syndrome, which we used in querying these databases. And we looked because the relationship between flu vaccine and Guillain-Barré syndrome, if a vaccine causes Guillain-Barré syndrome, it's going to do so within a relatively short time period after vaccination, say 6 weeks or 8 weeks. And so we really only needed to look for discharges of Guillain-Barré syndrome from the hospital during September to February of each year, or that's where we focused our efforts. And in those 4 states, using hospital discharge data, we identified about 1,200 discharges of Guillain-Barré syndrome. And if you'll remember back to the Sparks data lecture, you'll recall that it captures hospitalizations, not people. So one individual can be represented many times in a given year in the Sparks data, and people can even be hospitalized for the same condition repeatedly. And so what you see is that these 1,201 discharges for which we requested medical charts. We got 1,100 of them, and those 1,100 represented about 821 different patients. And looking about, again, which one of these individuals might fall inside our study definitions, we saw that 153 could be excluded because their onset of symptoms of GBS was outside the study period, and another 62 were hospitalized in the state, but they resided outside of the state, and we were going to consider vaccinations happening in the state, so those were excluded. And our final group of people in the numerator here were 273 people who were hospitalized with new onset Guillain-Barré syndrome. We had a case definition that allowed us to consider whether or not these were more definite or maybe with less certainty probable cases of Guillain-Barré syndrome. And that was after we had reviewed 823 medical charts, which in turn were vetted by an expert neurologist with experience in diagnosing Guillain-Barré syndrome. Then, to augment that surveillance system, first we got the medical charts, so we were able to go beyond what was in the hospital discharge data to get medical information from the charts and help us really narrow down. You can get a sense here, if we had only relied on the ICD-9 code, we would be overestimating the people in the numerator by a lot here. Once we were able to narrow down the numerator through chart review, we then needed to get information on flu vaccine status because it may not be in the medical chart where people were hospitalized. We needed to get this information from the individuals themselves. And so we set out to do phone interviews with these 273 cases, and you can see the breakdown here of who we were able to interview. And not only that, we wanted to also confirm, for example, if someone said that they were vaccinated for the flu in those years, we needed to know the timing of that flu vaccination and also confirm the receipt. So we were asking for permission from these patients to contact the provider where they received the flu vaccine to get the date and the timing, just confirm the fact of vaccination. And so we were able to confirm vaccination history for about 264 of the people, and also timing of vaccination, which we then needed to relate to their onset of Guillain-Barré syndrome. And what we found here was that 19 of these individuals had onset of Guillain-Barré syndrome within 6 weeks of vaccination. And as I mentioned, it's possible, given that timing, that those cases could have been caused by the vaccination. And then there were 32 people who had Guillain-Barré syndrome onset outside of that 6-week window, which makes it much less likely that the vaccine caused their Guillain-Barré syndrome. And then there were 116 people that reported not having any vaccination. And this is, sort of reflects what the vaccination coverage looked like in this population. So then you could see here of the ones that we call the vaccine associated, those that had Guillain-Barré syndrome onset within 6 weeks of their flu vaccination. You can see the distribution of timing here. So we're doing some descriptive analyses. We also relied on, the reason we picked these 4 states is because there were population level surveys on flu vaccine coverage in those states. And so we were able to go back and look at the proportion of people that were vaccinated by age in each of those 2 flu seasons here, shown by the 2 lines. This was the 92-93 season, and this was the 93-94 season. So flu vaccine coverage went up a little bit in every age group, and in both seasons it increased substantially with age, which is expected. In the 4 states, this represented about 21.2 million people. And these surveys gave us some of the data that we needed to estimate, you'll see, which we used this as an exposure data in the general population. So we got exposure information from the cases, and we got exposure information from the general population in the background. Whoops. Sorry. So we calculated rates of Guillain-Barré syndrome by exposure status and a rate ratio. Among the vaccinated people, the date of vaccination was obtained from the provider, which I mentioned, and the rate in the exposed or vaccinated people during the 6-week window after vaccination was the number of Guillain-Barré syndrome cases divided by the person time at risk after vaccination in the adult population in each state, which we used the survey data to calculate. And then the rate in the unexposed data, in the unexposed population, those who were unvaccinated or those who were vaccinated outside that 6-week window period, we used as the numerator the number of Guillain-Barré syndrome cases with no vaccination 0 to 6 weeks before Guillain-Barré syndrome onset, and as the denominator, the person time at risk in those who were unvaccinated from the survey data. And from that, we were able to generate Poisson models that looked at the rate ratio in each of having flu vaccination as it relates to the outcome of Guillain-Barré syndrome within 6 weeks of vaccination. And the overall rate ratio here in a crude analysis was 2.4. And in some other analyses of all patients where we adjusted for different factors or stratified by season, by age, and by gender, you can see some of the associations here. In general, the takeaway here is that especially for the 1992-93 season, there may have been some small increase in the risk of Guillain-Barré syndrome following flu vaccination. And the overall conclusion here was that there was not an increase going from one season to the next, but for the 2 seasons combined, the relative risk of 1.7 suggests slightly more than 1 additional case of GBS per million persons vaccinated against influenza. And so while the increase in the VAERS reports was very large, 2 or 3-fold over time, the risk associated with vaccination was not quite as high. So I think here, you then need to wonder, what was the cause of the increase in cases? And when you're thinking about a system like VAERS, it can be very complicated to interpret, but this increase could be due to increases in the efficiency of reporting cases to VAERS. It could be due to increases in vaccine coverage, which we observed from one season to the next, increases in the background rate of Guillain-Barré syndrome, or a small increase in risk associated with the vaccine. It's really the last scenario there that constitutes, we thought, a true positive signal and a problem with vaccine safety. But our study suggests that the increase in reports of vaccine-associated GBS was probably due to an increase in both vaccine coverage as well as the baseline incidence of GBS, but not so much to a large increase in the vaccine specific risk. We also tried to think about this in terms of how it relates to the risk associated with severe influenza. Since Guillain-Barré syndrome is a pretty rare outcome, and we estimated it to be about one case of Guillain-Barré syndrome per million people vaccinated, compared to the risk of severe influenza infection that can result from flu and can be prevented by vaccination. It does seem that the risk of Guillain-Barré syndrome is outweighed by the benefit of being protected against severe flu. The last example I want to present today is one going back to HIV, and it's where we conducted a surveillance-based comparison group analysis aimed at assessing HIV care coordination program effectiveness. So again, this is not necessarily the goal of the HIV surveillance system to look at programmatic effectiveness, but since the surveillance system exists, it lends itself to opportunities like this where we can get epidemiologic insights around program effectiveness. And so I'm going to try to show you how we did that for this particular program. The goal here was to assess whether this intervention is effective at improving HIV care outcomes in comparison to a usual care group. And why I think it's a good example for this particular lecture is because it's an example of how you can merge program or service data from the care coordination program with surveillance data to obtain outcome information on everyone. And then the second part is using surveillance data to select an unexposed comparison group of people who got usual care for a rigorous assessment of programmatic effectiveness. So I'll just give a little background about HIV care coordination to set the stage a little bit. And it was in 2009 that the City Health Department began implementing this comprehensive program called HIV Care Coordination at 28 Ryan White funded agencies around the city. And it's not just for every person in the Ryan White program who's receiving HIV care. It's an intervention that targets people who either have a history of poor care outcomes or are at high risk for poor care outcomes. And it brings together a package of different evidence-based interventions to help improve outcomes in the clients that it serves. It was rolled out as a service delivery program, and there was no plan to necessarily evaluate it, and there was of course, no randomized trial to assess its effectiveness. And so that's the background, and this is a map showing the geographic locations of the different care coordination program sites around the city, with the stars indicating the program locations and the background rates on the map showing the HIV prevalence rates in the New York City population. So the objective here to compare HIV viral suppression rates among care coordination clients over the 12 months following their program enrollment with that of a similar group of people living with HIV who, during the same time period, did not enroll in HIV care coordination. So how did we do this? Well, we started with information on care coordination clients from the eShare database that the health department keeps and that it maintains in the Ryan White program. And then we also have the entire universe of people who are diagnosed and living with HIV from New York City's HIV surveillance registry. And you'll recall that in the surveillance data, there's longitudinal information on everyone's CD4 count and viral load count since they've been diagnosed. And so this is the outcome information that we're interested in, viral suppression specifically. And by doing a match between the eShare database and the HIV registry, it becomes possible to know to identify the care coordination program clients in the registry. And so now it's possible to know their outcomes, and we're able to compare it to other people in the registry who did not enroll in the care coordination program. And so yes, we can get this outcome information for both groups. And we can select from among this other group of people who we know did not enroll in the care coordination program, we can select a comparison group to do this effectiveness analysis. And I'll say a little bit more about how we did that. And in each case, the outcome information is gathered in the same way for each comparison group. So step one was to identify those people living with HIV in the surveillance system. This is for the comparison group selection. How do we identify those people in the surveillance system who meet the eligibility criteria for the program but did not enroll in the program? And this is really kind of like a target trial approach is what we were really doing here. And so just to give you an idea how we did this, we identified people who had at least one laboratory report during the study period. And the other criteria included that they had not enrolled in the care coordination program as of March 31, 2013. And then we applied the eligibility criteria for care coordination using the data that was available in the surveillance registry. So we could identify, these were the enrollment criteria for care coordination, and we could operationalize them in the surveillance data. And so when we applied these criteria, that helped us identify about 63,000 people who never enrolled in the care coordination program, but met these eligibility criteria at any time during the time period. I just want to highlight too, the methods I'm talking about here were published by Michaeli Robertson. She was one of our epidoctoral students at the time. This paper is not in your readings, but I think if this kind of work is of interest to you, I highly recommend reading her paper to get a sense of more details about how we did this. So step two is that we can't just work with those people who met broad eligibility criteria. We need to identify a kind of time zero for this comparison group of people who didn't enroll in the program that we can match to or link to the enrollment date of people who did actually enroll in the program. And so, what we did here was to pick a pseudo enrollment date that defines the start of a 12-month period to assess the outcomes for this non-care coordination program comparison group. And to control for secular trends, these need to be matched such that the enrollment dates of the care coordination program or the enrollment dates of the non-CCP group, the distribution of enrollment dates mimics that of the enrollment dates distribution for the care coordination clients. So just to make it more concrete, if 10% of the care coordination clients enrolled in March of 2012, we would want 10% of the non-CCP comparison group to have a pseudo enrollment date of March 2012. And in this way, we won't be comparisons between the two groups won't be confounded by secular trends in the outcome. And so we would then assign these pseudo enrollment dates for the comparison group during periods or windows where they were we were sure that they were meeting the eligibility criteria. And we assigned, of the 63,000 that met eligibility criteria, we were able to assign a pseudo enrollment date to about 57,000 or 58,000 of them. And here in the red, we're showing the enrollment dates of the care coordination population, and next to them in blue, we're showing the matched pseudo enrollment date of the non-care coordination people living with HIV. So you can see that we were able to match the distribution quite well. So every person with a date here was either eligible and enrolled into the care coordination program or eligible but did not enroll in the care coordination program. But that wasn't it either. We needed another step here, which is to select the comparison group from within that population, right? So among those meeting the eligibility criteria, we need to identify and select those who are most similar in other ways to the care coordination program enrollees. And for this, we use propensity score matching of the care coordination program enrollees and the non-care coordination program enrollees. And we did this matching within different categories of people who were eligible for the program. So if you take the group of people enrolled in the program, about 7,000 people, you can see their characteristics here. And if you take just the 57,000 people who were eligible and who we were able to assign an enrollment date that matched the distribution of enrollment dates of care coordination program enrollees, you can see that they're really quite different populations from each other. So it's not quite, we need to take this next step of propensity matching to get a group that was more similar. And when we did that, we were able to identify from the 57,000 about another 7,000 people who were similar with regard to these and many other characteristics that we measured. And you can see here, after the propensity match, we have two groups that are much more comparable with regard to their baseline characteristics. Now, we were interested in the effect of the care coordination program on viral suppression, HIV viral suppression. So the idea is that when people enroll in the care coordination program, we expect them to achieve viral suppression within the 12 months after enrollment, and to achieve it at rates that are higher than those that are similar but don't enroll in the care coordination program. And what you can see here overall, this is showing the care coordination clients and the non-care coordination clients, or the usual care group. You can see that there's a slightly higher rate of viral suppression within 12 months overall. And when we looked within subgroups, you can see that this effect was a bit stronger for certain groups: those who were newly diagnosed at enrollment, and those who were diagnosed in the past but had no evidence of viral suppression at the time of enrollment. And these other groups were, we didn't really see much difference, much effect of the care coordination program on this outcome of viral suppression 12 months after enrollment. And in this second analysis here, we looked at a longer term outcome, which we call durable viral suppression. So how did the viral suppression rates at 13 to 36 months after enrollment compare in those who enrolled in care coordination to similar people who received usual care? And here you can see two things which I want to highlight. The differences are much less pronounced, really only limited to a positive effect in this one group of no evidence of viral suppression at enrollment. But the other thing I want you to notice is how low the viral suppression rates were. Really, even if there was a small effect of the program here, we would like to see these numbers, these percents, to be much, much higher. And so what we took away from this analysis was that there did appear to be some short and long-term benefits among certain groups, but those benefits were small, and there remains a lot of room for improvement. And you can see some of the details here, but we also took away that the potential for short and long-term impact of this program and further scale up could probably be increased by making some strategic changes to the care coordination program to improve its potential to have more impact. And these insights were gained through the experiences of the health department implementing the program, and also through some of our research. And I will say, after this study, the city health department redesigned the care coordination program, and we embarked on another project with them to evaluate how that new and improved version of care coordination worked. But I'm not going to present that here. But just to give you an idea of some of the takeaways of an analysis like this, and how it can be used to understand the impact of programs, and to inform their improvements and evolutions going forward. So in this example, I think we can think about strengths and limitations. We had a population-based comparison group that we constructed in a purely observational study. We were able to have, luckily, through the registry, a large enough sample of people who didn't enroll in the care coordination program that we were able to match using propensity scores, 99.6% of the original care coordination program sample. So through the propensity match, we didn't lose any generalizability to the larger group of people enrolling in care coordination. Another strength is that we didn't have to measure outcome data differently for each comparison group. They came from the same source, the registry, and that outcome information was available regardless of where people received their care. And the great thing about the registry is that all of this laboratory outcome information comes to the health department regardless of where the person receives care. So if they're moving around during the study, we still know what their outcome was. And of course, there are some limitations, right? We did our best to control for confounding using the information that we had in the registry, but it's possible that there was, uncontrolled or poorly controlled confounding due to things that we couldn't measure or include in the analysis. And also the propensity matching methods limits our ability to stratify the effectiveness estimates by things like sex and risk factor. So that's the third example. And just to wrap up here, I hope this gives you a little bit of taste of ways that you can go further than the routine uses of surveillance data. I think, and I've said earlier, that surveillance data are really sort of undertapped for these kinds of uses. But when you do them, they can help really set research priorities, and they can be used, as you saw here, to assess the effectiveness of policies or programs or assess other causal associations like we saw with the flu vaccine and Guillain-Barré syndrome. And you can often complement the surveillance data with other existing data sources, and that was happening in all three examples here today. But sometimes you can even do supplementary data collection like we saw with the Guillain-Barré syndrome analysis, reviewing of medical charts that we identified through hospital discharge survey data, and reaching out to patients directly to understand their flu vaccine history. As always, needing to understand the limitations of each surveillance system so you can understand how much you can really hang your hat on the findings that you've produced. Ideally, you have some insights on this before you even start, but sometimes it's hard to assess and before you get to the end of your work. And I also hope you take away from this that there's lots of room for creativity. It did take some thinking and planning and creative thought, I think, to design some of these studies, to have the ideas to, once you formulate the research question, the process of identifying a design using surveillance data or multiple surveillance data sources to do your best to address the research question, can be a fun, creative process. So there'll be some more examples of this next week that Jenny Shen is going to present to you. And I just want to end here today saying a little bit about the final exam that you'll be getting in a couple of weeks. It's going to be a take-home exam and open book. Unlike the midterm, it's not going to be timed except for the fact that you'll have about a week to complete it. So it'll be posted on December 11th, and you'll have until the 17th to complete it. You can open and review it at any time after the exam becomes available. You'll be allowed to complete multiple submissions as long as it's before the deadline, and we will do our best to answer any questions submitted around the exam or clarification questions that we can on Blackboard. That's it for today from me. I hope you all have a great week.